Today, we have the great pleasure of having Bruno Ramos Molina with us. Bruno is the group leader of the Obesity and Metabolism Research Group in Murcia, Spain, Instituto Murciano de Investigación Biosanitaria, IMIB, and Ramos was able to accept our invitation to talk about bariatric surgery as potential treatment of NAFLD. This is a very hot topic because NAFLD is booming. I mean, there's NAFLD or MAFLD everywhere. So I think that the possible approach by surgery, by reducing the weight, is going to be one important option. So Bruno, the podium is yours. Thank you again for your attendance and for your availability to give the seminar. And we are waiting for your presentation. Thank you.
Thank you very much, Claudio. If you can hear me right, okay? Or
we see your screen very clearly.
Okay. So thank you very much for the invitation. Very kind of you, Claudio, the co-organizer of your foundation. I really honor that a foundation like Fegato, I say all right, is
it's Fegato.
Fegato, sorry.
Fegato in
really expert in liver. That is my favorite organ, as I will say in the following slides. So as Claudio said, I'm young group leader, emerging group leader at the IMIB in Murcia, Spain, very small region. And I will talk about today, this afternoon already, I'm going to put this here, about NAFLD. I think many of you already know about this very relevant, important disease. I'm not going to do a big introduction about NAFLD again, because you probably know already, but just briefly mention that is, as you may know, a multifactorial disease that is affected by many environmental and lifestyle factors like obesity, but also sex, age, and genetics. And it's very associated with metabolic abnormalities, normally related to obesity, like you can see here, for example, insulin resistance. Can you see the arrow, or can you see my arrow?
Yes, we can.
Okay. Also dyslipidemia, prediabetes, inflammation, blood pressure. And I would like to focus in the not now, but in the second part of the talk about gut microbiota, because it's it's very well related with the disease, and also according to several works, it's also could be also related with not only with the physiopathology of NAFLD, but also changes that bariatric surgery induced in gut microbiome also can be related to the resolution of improvement of the disease. I will tell you about this later. And in this upper right part of the slide, you can see just a representation of a normal liver. These two livers that we found in our own cohort of bariatric patients. You can see some of them are normal. That is quite intriguing for me. Like as you might know, patients that are recruited for bariatric surgery are severely obese. But no they are some of them, they are not steatotic at all, as you can see. But other, as expected, are not only have steatosis, but also inflammation that are classified like as NASH, as you can see. Well, with regard to the management, just briefly mention that when you have an NAFLD in early stage, most of the clinicians usually recommend change lifestyle habits, especially diet and exercise. But when this cannot happen because the disease is already advanced, as normally clinicians used to use pharmacology medication to treat the disease. I'm not going to go further in this part because you probably might have already listened a lot about the pharmacology of NAFLD and NAS. So here today, I would like to focus on bariatric surgery. That is maybe you already know a little bit about that, but it's basically a surgical intervention for obesity. Just briefly say here that before continuing that last year was published a very nice guideline of bariatric surgery, so you can have an update information about when bariatric surgery is used and how what is the inclusion criteria of the patient, etc. Basically, the information that you can find in the guidelines is just define the bariatric surgery like it's a safe, basically just to mention that there's a long trajectory of data that demonstrate that the safety, efficacy, and durability of bariatric surgery for the treatment of severe obesity. But not only that, because usually it's recommended for people with severe obesity that this is defined with a body mass index of higher or equal to 35. But not only that, because also in the last year, he also recommended for example, obesity, regular obesity, that is defined for BMI higher than 30, and also several comorbidities like, for example, diabetes. The two most commonly used bariatric procedures can be basically they are sleeve gastrectomy, that is just a restrictive technique that is consisting in the removal of the most of the stomach, and gastric bypass. Okay, that is basically you bypass the intestine and remove. Well, you don't remove. You cut the stomach, but you don't remove the stomach, and you do a bypass in the upper part of the stomach. This is restrictive and also malabsorptive. Okay, and these both procedures are basically now the 90% of the surgeries that are now underwent in the global population, in this population with obesity. Okay, so just this is a study that was published several years ago that can give you an idea of how NAFLD and NAS is represented in the bariatric population. So, for example, in this study that included almost 2,000 patients recruited for bariatric surgery, you can see that simple steatosis was present in around 60% of the patients. This, I think, a relatively low percentage of patients, because, for example, in our own cohort, this percentage is higher, is around 80%, which is in agreement with other studies. Well, it's only show you here this one because it's also representative of other studies. What is also important here is to remark that NASH, that is basically steatosis in presence of hepatic inflammation and also liver damage, or like clinicians say, ballooning of the hepatocytes, is represented in the around 30–40% of the patient that is going to be operated by this kind of surgery. So, and what is the results of bariatric surgery in NASH in patients with NASH? But you can see, for example, in this study published in 2015, and you can see that all the patients here have NASH, that the resolution is quite high, in fact, after 1 year of surgery. And this is also in parallel with an improvement in steatosis and in NAFLD activity score. What is also another important data here is that according to this paper also published by the same authors in 2020, is that the resolution, the rate of resolution of NAS is quite dependent of the weight loss. You can see that the higher weight loss that the patient achieved, but the higher rates of resolution for NAS. And also, I would like to mention that there are a very recent paper published by Aminian and co-workers last year that not only improve NAS in people with in patients with obesity, but also bariatric surgery was associated with a significantly lower risk of incidence of major adverse liver and cardiovascular disease. Okay. But it's not all, everything is not the goal here. Is sometimes you can see also negative outcomes. So, for example, in this paper, published seminal paper, one of the first that used paired liver biopsies, as you can see, almost 15 years ago, that you can see that you can find an improvement in steatosis, NAS, and ballooning, as I already mentioned, not only 1 year after the surgery, but in comparison to baseline, but also is consistent with the time, so it's also durable. But the point here is that there are also several concerns, because in fact, bariatric surgery seems that it's not quite so effective to reduce inflammation in the liver and fibrosis. Okay, so this is something that also have to take into account. And I'm back to this study published in 2020 that you can see. Also, I already showed you this graph, but if you go here, is another figure from the same paper, that the rate of resolution of fibrosis is quite low, okay, in the patient. So it's something also we need to take into account. And this is also corroborated by other study published in last year. This is only in patients with advanced fibrosis, and you can see here on the right, that also the percentage of fibrosis is still high after 1 year or 2 years, even 5 years of surgery. So from this first part of the presentation, we can conclude that, okay, bariatric surgery is a quite fine intervention for weight loss and metabolic improvement. That is also very effective for steatosis reduction and NAS resolution, but have to maybe not so effective for fibrosis and resolution and to improve hepatic inflammation. So it's something that we need to investigate more here in this part. Okay, so now we go to the second part. And I would like to here going a little bit deep in the mechanism that have been related to the effect of bariatric surgery, not only in a patient in general, in all the patients with obesity. So as you can see, several mechanisms have been proposed, but in this very nice review published also very recent. And among these mechanisms have been proposed that the bariatric surgery induce a reduction in brain hedonic response to food stimuli, for example. And also interesting is that improve glycemic control by increasing the production and release of insulin in the pancreas, and also improving the insulin sensitivity. Also have an important role in the resorption of intestinal bile acids. And of course, this well-known effect that this has increased the secretion of gut hormones like incretins and other satiety or hormones like PYY. But what I would like to focus in this part of the presentation is that the effect of bariatric surgery can have in the gut microbiome, and how these effects can also have a role in the effect of bariatric surgery. Okay, so before going to this data, just briefly mention that the gut microbiome, that several multiple preclinical and clinical studies have already highlighted a role of the gut microbiome in NAFLD pathogenesis. This is not new. I tried to summarize the most important result, more consistent results of in human subjects in this table. And basically, the NAFLD is characterized by an increase in proteobacteria and bacteroidetes, and a decrease in firmicutes and actinobacteria. Okay, but not only that, but this also have it also described that intestinal bacterial overgrowth is present, and also there is an increase in intestinal permeability and intestinal inflammation. So if we go to one of the first studies published about this regard, we published with you et al. In pathology in 2013. You can see that, for example, if you analyze the data at the phylum level, this is, you compare three groups here: if normal, if non-obese versus obese and NASH. You can see that bacteroidetes and firmicutes, there are no differences between obesity and NASH. So, but you can see, if you go to the right, it seems that there is more consistently changes and comparable when you compare the obese with NASH. So maybe this kind of this type of phylum is more associated with the pathology. And if you go down here, you go further, instead of just phylum, and you go to family, bacterial family of bacteria, you can see that especially in NASH, this family Enterobacteria is quite increased, and specifically Escherichia. Okay, so it's a very well-known pathogenic bacteria, but this could be also a role in hepatic inflammation. So this is not the only one, as I mentioned before. So there are others. I just briefly mentioned this one published in Nature Communication that also describes several differences in gut microbiome between patients with and without fibrosis. I would like to remark here maybe the decrease in Fecalobacterium pragnici, and this is a very well-known bacteria that produce short-chain fatty acid that I will tell you about them later. So, how the bacteria is associated with the disease? So basically, bacteria produce and release several metabolites and factors that could participate in the progression of the disease in NASH. So on one part, you have gut microbiota derived factors that can be act as drivers of the disease. For example, you have lipopolysaccharide, and you have also some gut microbiome metabolites like with hepatotoxic functions like lactate or ethanol. Even ethanol can produce by bacteria, so you can have even high ethanol in your circulation, even if you don't drink alcohol. So this is also very interesting, and also TMAO. And not only that, but you also have gut microbiome can also have an important effect in the pools of bile acids that can also affect the liver function. And on the other part, you also have other metabolites called short-chain fatty acids, I already mentioned, acetate, propionate, and butyrate, that they have a more beneficial effect in the liver. So normally when you say you have a dysbiosis or alteration in the gut microbiome, in this patient, you can observe that there are an overgrowth of bacteria that produce more hepatotoxic molecules, and a decrease of bacteria that produce short-chain fatty acid, that they are more normally bacteria that can transfer or can produce these molecules from dietary fiber. Okay, so having said that, we can going back to bariatric surgery. So it's also several different studies that have also described that that bariatric surgery induced taxonomical and functional changes in gut microbiota. And these changes happen shortly after surgery and are associated with metabolic improvement. Okay, I also tried to summarize here in a table what I found in the literature. So also there are some similarities and differences depending on the type of surgery that you select. I would like just to mention here, because to me it's one of the most interesting changes that can be observed after surgery, is an increase in Akkermansia. And why? Because Akkermansia mucinifila is a bacteria that have been involved in, have been described to have a beneficial or protective role against NAFLD. Basically, this is based on some studies in mice, in mice in which have been induced NAFLD using a high-fat diet and have been also treated with oral Akkermansia mucinifila in these animals, and have been observed that the treatment with this bacteria is able to reduce lipogenesis and inflammation in the same liver, but not only that, but also is able to reduce or restore intestinal barrier integrity. And why is this important? Because this can induce reduce endotoxemia and leaky gut. Therefore, can also have an important role in the decrease of liver inflammation and oxidative stress and liver insulin resistance. But bariatric surgery is not only characterized by inducing changes in bacteria, but also in metabolites that are related to gut microbiome. So, for example, it's also very well known that specifically gastric bypass of malabsorptive surgeries induce changes in the pulsion of bile acids, which in fact can also are related with metabolic effects shortly after surgery, independently of weight loss. And normally these effects are mediated with two different pathways, the FXR and TGR5, which are also related with regulating inflammation, insulin sensitivity. Also, an important data here is, to me, is quite interesting too, is that apparently there is a higher increase in bile acids levels in patients with type 2 diabetes remission after surgery, in comparison with those that don't remit. So maybe the bile acid can also have an important role here in the resolution of diabetes after surgery, but we need confirmation. Other changes that can be induced by bariatric surgeries, there are increases in short-chain fatty acids, especially studies have shown that the changes are producing at the fecal level and have been also associated with improvement in metabolism and glucose homeostasis, because basically they can not only are anti-inflammatory molecules that also can affect the metabolism and insulin sensitivity. So what we are doing here in Murcia specifically, so basically what we are doing is a longitudinal study in which we are recruiting bariatric patients, and we are collecting samples of, we have liver tissue, for example, that we collect during surgery, and we also have blood and feces, and also we do a follow-up. We are right now collecting sample of this all of these visits after surgery. So, and what we are trying to investigate here is if, for example, the gut microbiome profile and also the metabolomics related to the gut microbiome can help to predict the response of the remission of NAS fibrosis after surgery, because as I told you before, there is also a quite significant percentage of patients that don't remit after surgery. So we would like to know if microbiome can help to predict this response. And what we are doing basically is to study changes in microbiome, but not only that, as I told you, also do a metabolomics in parallel. And also we study inflammation and intestinal permeability in this patient. So just to show you a very, very preliminary results, because these are not, we are still trying to analyze this data. Or right now, no, we present you an update of our patient. This is around 80 patients, if I remember well. So we could classify in 3 groups in normal liver, as I told you before, in NAFLD, basically fatty liver and NAS. And we found that, for example, in NAS, there was a specific increase in actinobacteria. This, I remind you, is at phylum level. Also, an apparent increase in bacteroidetes, but it's not so high. But this also, what is quite also interesting here is a decrease in proteobacteria. And with this, also important here is to mention that they are also not specific of NAS, but it's also with a specific of NAFLD patients, fatty liver and NAS, is an increase in fusobacteria, as you can see here in green, and also an increase in the sulfobacteria. And also it's seen that is a decrease in firmicutes in comparison with the controls. If you go to the genus level, we'll show you here with the arrows. What is also for us quite interesting is that NAS patients specifically showed an increase in bacteroides and bifidobacterium, and a decrease in Prevotella, which is more or less in line that have been published in 2015 in pathology. As you can see here, you can see the bacteria. I think this is family levels, and I'm showing genus, but more or less is, sorry, without the mouse. So here the increase in bacteroides and decrease in Prevotella, I think bifidobacterium is here, so you can see more or less similar that we found. And we are trying to analyze also at this moment is the response of the changes or the changes of gut microbiome after bariatric surgery. In our case, most of the patients undergo gastric bypass. You can see, for example, like 6 months after surgery, you can see a significant reduction in bifidobacterium and an increase in Prevotella, which I think quite promising and maybe can help also to predict the response to surgery. And just before finishing, I will also like to show you a paper that we published several months ago. We saw, if you remember, I already told you that that bariatric surgery induced changes in Fegato short chain fatty acids. So we realized that nobody have checked the changes that are produced in plasma. So if this short chain fatty acid also reach circulation if the surgery induced changes. So as we publish in this short paper that effectively bariatric surgery can induce, especially at 12 months after surgery, an induction if butyrate and propionate that, as I told you before, was related to improve inflammation. And when we did correlation, we found also that correlate negatively and significantly with BMI, changes in BMI, and with also with insulin resistance. So just to summarize the talk, I hope that I convinced you that bariatric surgery can be considered as a therapeutic option for patients with NAS and obesity, but maybe could not be sufficient to reduce liver inflammation and fibrosis in NAS. In patients with severe obesity, we don't know in other kind of patients, we need to focus. And I will end with a question as just to very short question. Could the macrobiota profile help us to understand the contribution of bariatric surgery to weight loss and NASH revision? We don't know. We are working on it right now. So just to ending, just to giving thanks to my lab members at Murcia. This is the hospital, the Arrisaga, where we get the most of the biological samples, and also, of course, the clinician that help us with the clinical study. So thank you very much.
Thank you very much for this excellent presentation, Bruno. You can remove your screen and then put your picture in front of us so we can have some discussion. I really appreciate your presentation. It was clear and very promising.